Today we'd like to share our paper, Effect of the Coronavirus Disease 2019 Pandemic on the United States EMS System, a preliminary report. This work was supported by the Health Resources and Services Administration, their Maternal and Child Health Bureau, EMS for Children program, and the information and content does not represent their official position or policy. As the effects of COVID-19 evolve, it's important to understand the pandemic's effect on our healthcare system and population. Early in the pandemic, efforts were made to decrease virus spread. As communities implemented social distancing interventions, they messaged the concept of reducing virus spread and decreasing burden on the healthcare system. This message was explained in the popular media as an effort to flatten the curve, and the image shown here began to appear widely. Along with it, new patterns emerged in access to medical care. Initial reports showed dramatic decreases in emergency department visits, both across the United States, where visits were cut in half, but also you can see a dramatic decrease in emergency department visits were also seen in the New York, New Jersey region, which at the time was seeing a spike in COVID-19 cases, including deaths. Anecdotally, emergency physicians and other emergency care providers reported fewer patient visits, but higher patient acuity in the United States. These reports were supported in other countries where they too saw a drop in ED visits and an increase in patient acuity. The need to determine the effect of the pandemic on the emergency medical services system was identified. There were anecdotal reports of a sharp rise in 911 calls for cardiac arrest, but there were no reliable scientific reports. Our team worked to quickly quantify trends in national EMS responses using the NEMSIS, or National EMS Information System, which collates medical record data from agencies across the country. We used the NEMSIS database, which populates a national EMS registry, including standardized patient care records submitted by over 10,000 EMS agencies across 47 states and territories in near real time. Transmission of data to the National EMS Registry is automated in most systems so that once a patient care record is completed, the record populates the associated state and national registries automatically. This means in times of high call volume and high workload, the data is still available. We were able to analyze over 37 million EMS calls across the United States for the years 2017 to 2020. The number of states submitting to the National EMS Repository increased over the study period, where in 2017, 32 states were contributing data, but in 2018, 40 states, 2019, 44 states, and 2020 increased to 47. States enrolling in the National EMS Repository commonly begin submitting PCR, or patient care reports, at the beginning of the calendar year, which may explain the week one spikes shown in this table. No state stopped submitting PCRs once enrolled, and the graph shows a decrease in call volume starting in March that is not mirrored in the previous years. In fact, there was a 140,000 call drop in volume from week 10, which began March 2nd, to week 16, which ended April 19th. The analysis was run on June 3rd, giving agencies sufficient time to submit their data through April. Next, we looked at the number of EMS-attended deaths or cardiac arrests. We found the proportion of EMS activations reporting a patient disposition of death at the scene or cardiac arrest remained fairly consistent until the 11th week of 2020, at which point the proportion of scene deaths nearly doubled, increasing from 1.5% to 2.8% among all EMS agencies, with patient contact by week 15. Looking at the raw numbers, the number increases from just over 6,000 deaths in week 11 to nearly 9,000 deaths in week 15. We also looked at the number of injuries, assuming that those patterns may have changed due to stay-at-home orders. What we found was that the proportion of patients attended by EMS for which a potential injury was reported demonstrated a decrease in EMS activations, falling from 18.4% in week 10 to 15.3% in week 13, with the actual number of EMS activations for injury trending downward for this 3-week period from just over 98,000 to just over 66,000. So why do we care about this? Well, this has serious healthcare implications. For one, it may illustrate behavior changes that are occurring amongst the citizens served by these EMS agencies. We did see a reduction in coronary syndromes reported in the US, Spain, and Australia. And in the US, a study of people who delayed seeking care for myocardial infarction showed that a third were afraid or didn't want to burden the emergency department at the time that they experienced chest pain. Our finding is positive if people who don't need resources are staying home, but the doubling of deaths in the United States and Italy indicates that this is unlikely. Further, a Portuguese study found excessive deaths that were not explained by COVID. So it is of concern that perhaps this decrease in call volume is related to people who need care not seeking that care. This also has implications for our frontline providers. High acuity patients are more stressful, especially if there's negative outcomes are avoidable if they had sought timely care. This could result in long-term negative consequences for EMS professionals in terms of their health, well-being, and longevity in their careers. The other issue is the economic impact that this is creating. EMS agencies schedule units, so there's always capacity. If all EMS units are responding at the same time, there will be no capacity for the next emergency. However, too many idle EMS units increases the cost of maintaining the EMS system. Further, most EMS agencies earn revenue only when they treat and transport patients. Communities frequently require a certain number of units to meet response time requirements, so a drop in call volume will result in agency costs that are likely flat, since the agency would be required to have the same number of units in service in order to meet those response time requirements. And so having flat revenue or having flat costs while call volumes decrease could result in decreasing revenues, which could lead to budgetary shortfalls that will be difficult for these agencies to recover from in the future. So this study showed that early in the COVID outbreak, there was a significant decrease in EMS responses. Simultaneously, the rate of EMS-attended scene deaths doubled, and the rate of EMS activations related to patient injury decreased. The effects of COVID-19 are still evolving, but there is a need to understand and react to the impact of the pandemic on our EMS systems to make sure that we're maintaining the health of these systems. So early, simple analyses that show us what's happening are very important, and we're proud to have been able to bring you this study. Thank you.